This is TTT Live. I'm DK Rostar. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Chalk City 91.1 FM, Sweet 100.1 FM, Next 99.1 FM, and on Facebook at TTT Live Online. We go now to the Manager, Corporate Communications at the Ministry of Health, Candice Alcantara.
Good morning. Today is Monday, the 7th of September, and we are pleased to have you with us again for the Ministry of Health's virtual media conference, which delivers an update on the Ministry's COVID-19 response. On my left, we have the Honorable Terence Deyalsingh, Minister of Health, and Dr. Avery Hines, Technical Director of the Epidemiology Division. Also in studio is Grace Sukhchan, Manager of the Expanded Program on Immunization. I'm Candice Alcantara, Manager of Corporate Communication at the Ministry of Health and the moderator for this morning. Minister Deyalsingh will lead us off with his opening statements.
Thank you. Thank you very much, Candice. Good morning to all. Today is today is Monday, the 7th of September. Let me just make that correction on my notes here. Good morning to Dr. Hines and good morning to Miss Grace Sukhchan, who will talk to us this morning about the importance of vaccinations for children. Good morning to ladies and gentlemen of the media and to all who are listening wherever you are. Very good Monday morning. Before I get into what we are noticing in the latest trends locally, it is always good to give the population some idea of what is happening globally. There has been a development within the last 24 to 48 hours where India has now overtaken Brazil as the country with the second most number of infections. The United States continues to be first with about 6.4 million infections. India is now 4.2 million. Brazil, which used to be second, 4.1 million. And Russia, which used to be around 800,000, 900,000, they have now joined, unfortunately, that list of countries with 1 million cases and over. They are at 1,030,690. India actually saw its biggest one-day increase yesterday. I believe the figure was 900,000 cases or something like that. There was another incident in England, because I'm telling the country this so you can see what is now driving the second wave. What is driving the second wave are social interactions. A particular football club in England held a charity match, and due to lack of proper precautions, that charity match resulted in 300 new cases. Just one charity football match. And that is why we took the decision, the Honorable Prime Minister, when he announced the newest measures 3 weeks ago, that all contact sports will not be allowed. This is why, because we know what will happen with contact sports. Dr. Hines will talk to you and I will introduce the topic about, and we have said it before, that the new demographic that is driving this second wave is in fact the young people. And coming out of the UK, the direct quote is, the second wave is being driven by young people who don't follow social distancing rules. And this is being borne out by what we are seeing as a change in demographic in Trinidad and Tobago, and Dr. Hines will go into details, where he will talk to you about the new phenomenon in Trinidad where under 19s, not an under 19 football club, but those people under 19, what are the figures for that demographic? And what is partially driving our second wave is the demographic of the 25s to 49s who are taking the virus home, infecting the families, infecting the elders. Ladies and gentlemen, we have been instituting a series of measures. Most recently, we had to go the legislative route to make the wearing of face coverings, including masks and or shields or any other type of face covering, now against the law. Coming into Port of Spain this morning, I am still seeing people, even though the police have been charging people on the Sawa taxi stand, you are still seeing passengers not wearing masks. You are still seeing people at the Quasi Promenade who have the masks and who insist on having it under their chins. You are going to be fined. Avoid the fine. Just wear the mask properly. The second thing, and we just came out of a meeting this morning with nurses from Northwest RHA, with the Chief of Staff and so on. And although we have put out these guidelines, what is currently, let me get the camera correct, what is currently partially driving the surge in cases is bullet point number 3 that we have on these things. And that is stay home if you are ill. We are getting more and more reports from companies, both in the private sector and also the public sector, including health. We are not immune to this, where people are going to work knowingly ill, and are infecting whole workforces. And this is going to put a tremendous strain on the public health sector. I don't think we can legislate against that one, but we are appealing once again. The 2 main drivers for this second wave are the behavior of young people between the ages of 25 to 49, and 2, the insistence of people who are ill, knowingly ill, going to work and infecting whole departments. We are again appealing to those individuals who are ill to stay home, see a doctor, get tested, isolate yourself. So, Ms. Alcantara, these are the global developments. These are the local developments that are contextualized in what we are seeing globally. Young persons are now driving this second wave across the world. There was the mayor or the governor from Miami this morning who was speaking on CNN, making the same point, that even though their beaches are open, what happens in Miami is that after the beaches, the young people go to their underground parties, they go home, they consume alcohol, their defenses go down, and he is noticing the same thing across the whole state, that all of Miami. We are again appealing to young persons who want to go in their social gatherings. This is what is driving this second wave, and we appeal to you to do 2 things. Resist the temptation for social gatherings, especially if it entails alcohol, because your defenses go down. What you will normally do when you are in control of all your faculties, you will not do when your inhibitions go down. And 2, my very last point to reiterate, if you are ill, please stay at home. Thank you very much, Candace, for your consideration over the past 5 minutes or so.
Thank you very much, Minister Dayal Singh. And Dr. Hines will now provide us with a clinical update and a report on Trinidad and Tobago's epidemiological status as it relates to COVID-19.
Thank you, Ms. Alcantara. Good morning to the Honourable Minister, to my colleague, Ms. Sukhchand, Nurse Sukhchand. Good morning to the members of the media and to the members of the viewing and listening public. Today I'm going to be giving the clinical update, both the testing and the hospitalization figures, and then we will go into some more detail on the epidemiologic presentation as it stands at present. So the update for Monday, 7th September 2020 is as follows. The number of samples submitted to the Caribbean Public Health Agency stands at 25,140. Of those, 22,218 are unique tests. There have been 6,130 private sector tests submitted, which brings the total number of public and private sector tests to 31,270. The number of samples testing positive to date stands at 2,254. There are currently 1,485 active cases, and there are 35 deaths. There has been one additional death since our last update, and our condolences are extended to the members of that family. The number of persons discharged stands at 734. Now, we would note that we've had 4 additional persons noted as positive between the last update and now, and again, given the testing flow, we note that not all of these cases were cases that would have occurred or would have been tested yesterday. When I go into the epidemiologic situation, you'll see more clearly what we mean when we say that. With regard to persons in hospitals, we have hospitalized 105 individuals spread across the Couva and the Cora facilities. At Couva, there are 77 individuals, 6 of whom are in ICU, 12 of whom are in HDU. At the Cora Hospital, there are 28. There were 5 discharges from each of those institutions. At the hospitals where we house our suspected ill cases, still awaiting a test result, we have 66 at Arima and 6 at the Augustus Long facility. And in the step-down facilities, we currently have 4 persons at the D-Bay facility, 1 at Napa, and 33 at UE Freedom Hall. We have 168 persons in a mixture of state and state-supervised quarantine, 96 at the Paria facility, 13 at Cascadia, 21 at Regent Star, 12 at Chancellor, and 26 at the Home of Football. That brings me to the end of the updates regarding the statistics as at Monday, September 7th, 2020. I turn you back over to Ms. Alcantara.
Thank you very much, Dr. Hines. And we go back to Dr. Hines for the epidemiological update.
Okay, now what I'm going to do is I would like to take some time to explain a little more detail concerning the cases that we have been describing. We will show a few slides. I'm going to start with slide 1, which is the introductory. So please go to slide 1, and it's just really demographic characteristics, which explains age and sex and geographic distribution. And then we'll speak about the epidemiologic curve. So slide 2 is the first slide that shows us the age and the sex distribution, that demographic information that we're speaking about. And as you can see on the left, we have what you call an age-sex pyramid, showing on the left of that left side figure, the blue half, the number or the percentage of males in various age groups, and on the pink half, the right side, percentage of females. What we have been seeing overall is that there is a preponderance of males over females. The 25-year to 49-year age group is the most affected. It's also one of the larger age bands within the population. So the males 25 to 49 are leading the pack. We do find that between 50 and 59 years of age, women outnumber men, but overall, there are more men than women diagnosed as positive within our system. The bottom of the graph is a little hard to see because of the ticker going across the bottom of the screen, but thank you. That's wonderful. Thank you. But we can see from the last 1, 2, 3, 4, 5 age bands is that those persons between 1 year or under 1 year and 19 years of age are actually about 10% of the entire population of COVID positives at this point in time. So those are the main points to make regarding the age and sex distribution. We can go to slide 3. Slide 3 now deals with the geographic information. Some of this information would be familiar to us. This slide shows the distribution of cases in both the first and the second waves, shown by red for the first wave and blue for the second, and the purple or pink, depending on the color you see on your screen, really shows the repatriated and immediately quarantined cases. To simplify the graph, we move to the next slide, which just shows the second wave, second phase, and separates those who were quarantined from those who have been diagnosed in the population. The important bit of this is really to explain that as the number of cases increases, we have to adjust the size of the circles in such a manner that we can fit all of the identified cases in communities onto the map. So you actually have to read the legend carefully to understand that what would have been 5 to 10 cases in a previous version of the map now stands for a larger number. We move to the next slide, which just shows the phase 2 population-based cases. And what we do see here is something that we want to let's go back for one moment. Let's go back 2 slides. Let's go back a slide. Yes, but what we want to show here is the distribution of cases across communities, numbers in communities represented by different sizes of those circles. And as we see in the following slide, the heat map, as we like to call it, of the population for Trinidad and Tobago. This is the entire population, with the brighter areas showing the more densely populated parts of the country, and the darker areas showing the less densely populated areas of the country. We see that basically the virus follows the population distribution. Where there are people, there is virus. There is more virus where there is more dense population, and you see fewer cases in the less densely populated areas, as we highlight in the following slide. So this is now the heat map just for the cases as opposed to the one before, which was the populations. You basically see almost the same distribution, and that's why I have to make the distinction. So in this case, we are seeing that the Port of Spain and the East-West Corridor, the Chaguanas, Hoover, Caroni area, San Fernando and environs, Arima, Sangre Grande, all of the population centers or hubs are concentrations of cases. But lest you think that they are concentrated only in those areas, the following slide shows the distribution of cases a little more in a little more disaggregated fashion. And this, without showing the specific pinpoints of where individual cases may lie, shows numbers of cases by a smaller geographic area than a community or town. And it allows persons to understand that there are more cases around the population centers than the initial or the previous graphs may be giving you the impression that there are. We need you to understand that there is nowhere where there are no cases. There are cases wherever there are people, and therefore we are asking people wherever they are to follow the guidelines given with regard to reducing the risk of transmission of COVID-19 in their day-to-day interactions. We're going to move to the next, which is the epidemiologic curve. The next slide shows what we've been describing. We do see that there has been, across the July 20th to September 6th time period, July being the months in blue, August being the months in purple, and September being the months in, or the bars in the darker blue, navy blue. We do see that there has been a rapid increase from the end of July into August, that the number of cases, while they don't quite match the number of cases per day given by the updates, this version explains better how many people would have presented to health facilities and tested positive day by day when we break the information down and we disaggregate it across the days when they presented. So we still do see that increase. We see that as we come towards the end of the graph, we are seeing smaller numbers, but we do expect that as updates roll forward, those numbers may increase slightly. But we are attempting to get the understanding across that while we are seeing larger numbers, the massive totals that would be reported and sometimes picked up on by headlines, 200 new cases in a day, that's not actually what's happening on the ground with regard to persons coming to the health facilities for testing. The highest number there is a little over 100, I believe. 113 would be the highest number, the highest peak on that graph. So we can close the slide presentation, and I just want to make a couple important points. First important point regarding the geographic distribution is a point that answers some of the questions about why we don't specifically say where cases live or where they are. At this juncture, it does not matter where an individual case is. What we do need people to understand is that your general conduct over the foreseeable future should be such that you reduce your risk of coming into contact with ill persons, you reduce your risk of transmitting illness to other persons if you are ill, you reduce your risk of inadvertent contamination via the hygiene procedures and practices that we have been advocating. And the exact location of any of the cases is not so much the issue as the general behavior that is required and expected and being encouraged by the public health regulations and advice that has been given. And the second thing is that the age groups go from the very young to the very old. While we do have the 25 to 49 age group highlighted, we do note that cases under 19 have been occurring, and the cases above the 25 to 49 age group have been occurring and have resulted in many cases in higher rates of fatality. So when we emphasize that a fatality has had pre-existing conditions or that they're in an older age group, we are really sending a warning and asking the persons in older age groups and with pre-existing conditions to be extra vigilant, to be extra aware of their health status, and if they are unwell, to contact the health system early so that we can have beneficial and healthy outcomes for them. With that, I turn you back over to Ms. Alcantara.
Thank you very much, Dr. Hines. Ms. Sukhchand will now present on immunization for children.
Thank you, Ms. Alcantara. Good morning, Minister, Dr. Hines, and to you, the viewing and listening audience. The COVID-19 pandemic has had a significant economic, social, and health impact on the population, as well as placing a burden on health services. Immunization continues to be an essential service that must continue to keep people healthy and reduce burdens on health services so they can respond more effectively to COVID-19. Prior to the pandemic, the Ministry of Health had embarked on a campaign to vaccinate to prevent serious respiratory illness from flu and measles outbreak, which countries such as Brazil, Argentina, Mexico, and Venezuela is currently facing. Even though we had to postpone the vaccination campaigns due to physical distancing measures implemented to reduce transmission, please note that the national immunization program was never suspended. It continues to provide protection from vaccine-preventable diseases to our most vulnerable, despite the challenges faced with the pandemic. The Ministry of Health has been monitoring the disease impact on vaccination coverage. The current vaccine figures for the first half of 2020 revealed a decrease in coverage compared to the same period last year. Although there is adequate supply of vaccines, we have noticed a decline in public demand for services. We are aware that the main cause has been people concerned about the risk of exposure to COVID-19 if they seek vaccination services, difficulties due to limitations in public transport. Initially, there was the lockdown and physical distancing. However, on March the 18th, the Ministry of Health had put forward guidelines to ensure that the immunization of children at all primary healthcare facilities was carried out uninterrupted while maintaining the safety of both the public and staff. These include and are not limited to a block appointment system to prevent overcrowding. Clients were contacted via phone to set up appointments and also as a reminder to keep appointments. Staff was advised on social distancing, use of masks, hand washing between cases, ensuring clients was attended to in the shortest possible time, and client seating arrangement was spaced to ensure social distances. Please note, we always had a full complement of staff at all the health centers. So what are the risks of not sustaining a high coverage of vaccination risk? We run the risk of importation or reintroduction of vaccine-preventable diseases and increased death due to communicable diseases. We are therefore asking parents and guardians to look at your child immunization card. And if you look at the immunization card that is provided at your health facilities, you would notice that at the back of the card, the schedule that tells you what vaccines your child is supposed to have and at what age. The inside of the card also clearly states it as well. If you are unsure of what vaccines your child requires, or you look at the particular vaccine for the age and realize your child did not get the vaccine, please contact the health center, speak to a nurse who will advise you, set up an appointment for you to bring your child in so that your child can be vaccinated. We are currently facing a pandemic, and no country, including Trinidad and Tobago, can deal with another outbreak of disease, especially diseases that can be prevented with vaccination. We are urging all members of the public, ensure that your children are well vaccinated, ensure that the appointments are kept. If you cannot keep an appointment for a particular reason, please contact the health center to reschedule your appointment, but to ensure that your children is booked for their vaccination and vaccinated accordingly. Thank you, Candice. Back to you.
Thank you very much, Ms. Sukhchand, for that very important advisory. And we go to the question and answer segment at this time. I believe that all our representatives are familiar with the requirements. Please state your name, the media house that you represent, and please a maximum of 2 questions. And if you get to the point of the question, we can take more questions. Our panelists will now respond to questions from the media. We begin with Guardian Media Group.
Hi, good morning, everyone. Guardian Media Limited, Rashad Khan. 2 questions. One, the first one, I don't know if the Minister or Ms. Sukhchand would like to respond to it. There is a substantial anti-vaccination movement around the world and even in Trinidad and Tobago. How much of a threat could they be locally to this immunity that you're trying to get the country up to? And my second question is to Dr. Avery Hines, and I'm glad you're here this morning. Over the past week, almost every day, we saw deaths due to COVID-19 occurring. On Tuesday, we had our highest number. We saw 5 being recorded. Do you have an explanation as to why all of a sudden we've seen this jump in deaths, and also how many of these persons would have died at hospital or outside of home, and where were they warded?
Okay. So Richard, yes, thank you and good morning to you. Thank you for the question. From a policy perspective, you are quite right. WHO has identified the anti-vaxxers movement as one of the top 10 public health concerns facing the world. It had its modern origins. This goes back many years. It had its modern origins in the 1990s with Dr. Wakefield in England, who published a totally false report that MMR vaccines were causing autism in children. That was picked up by some religious groups, some politicians, and unfortunately made it shows to Trinidad and Tobago. I don't want to go into the details, even among the medical fraternity, unfortunately. We continue to tell the public that vaccinations has saved millions, tens of hundreds of millions of lives around the world. And the risk of any adverse event out of vaccinations is so minuscule as to very often not even register on the scale. Vaccines are safe. They are effective in combating childhood diseases. And again, we appeal to people to stop pushing your anti-vaxxers theories. And I will now turn on to Ms. Sukhchand to tell you the benefits of vaccinations.
Thank you, Minister. And that is indeed a very important question. This is an issue that not only Trinidad and Tobago is dealing with, but as Minister said, it's a worldwide thing. However, our statistics in Trinidad and Tobago has shown that vaccination works. We have not had an outbreak of polio or measles for over 2 decades. Our statistics have shown that it is working in Trinidad and Tobago. We do have an issue with anti-vaxxers, but not in a large proportion. Our viewing public out there would understand the importance of vaccine. We were vaccinated, our children were vaccinated, and we've not had a problem with the vaccines per se. All in all, I think we are doing well with our immunization program. We have proven that vaccines work. We have proven that this program is a very important program put forward by the Ministry of Health. In Trinidad and Tobago, vaccines are free of charge, and our public is responding positively to this.
Ms. Sukhchand, and I already want to thank Rashad for pursuing this vaccination thing. It's important in the light of COVID, so I'm not trying to deflect from COVID, but in the context of COVID, and Nurse Sukhchand could give you the figures, I believe we need to attain a vaccination rate to get herd immunity for MMR of between 95 to 97%.
That's correct.
And I think you need to explain to the public that that MMR vaccine is now a 2-stage vaccine. So please go into details whether we are right with 95, 97%. And please explain to the public the 2-stage vaccination process now for MMR.
Thank you, Minister. So we have the MMR vaccine that is given at 1 year of age. And the second dose, which was previously given between the ages of 4 to 5, has now been readjusted to 2 years of age. Minister is right in that we need to achieve 95% coverage to prevent an outbreak. Now, if 95% of the population is vaccinated, it means the other 5% who are not vaccinated would be covered with what we term herd immunity. We have to remember not everyone will be able to take a vaccine. It depends on person's particular disease condition or immunogenicity. So a doctor may state that based on a person's particular condition, they may not be able to get the vaccine. And because of that, the 95% coverage will provide protection to them, meaning that persons would not be transmitting the disease. If you have 10 children in a class and all 10 can't get the vaccines, you want to ensure that at least 95% of the students in that class is covered with provide protection. Vaccines such as MMR, you must acquire 2 doses in order to be fully immunized. If you take 1 dose of the vaccine, you are only, again, 95% covered. If, however, you take the second dose of the vaccine, your body had enough time to build up immunity, and then you are more than likely 100%, between 97 to 100% protected for the vaccine, and therefore unable to spread to anyone else, to contact the disease and spread it to anyone else.
Thank you very much, Minister and Ms. Sukhchand. And we go now to the second question from CNC3 Guardian Media, and Dr. Hines will respond.
Okay, thank you, Ms. Alcantara. If I may, I just want to tack on an epidemiologic perspective to the vaccination discussion, and it's a very simple and an obvious one. One of the things that we have seen in recent times is outbreaks of measles, outbreaks of mumps in places where you would think that based on the strength of the health system, those outbreaks would not occur. We've seen them happening in the US, in the UK, in Europe. And the reason for that is that the behavior of persons in moving away from taking the routine vaccines has dropped their coverage below the requisite level to allow for that herd immunity protection that we've been speaking about. In the Caribbean, our populations have been well educated and are a little wiser in their choices, and we have been maintaining our vaccination coverage, and therefore we have not been seeing those outbreaks as alluded to by Ms. Sukhchand. So that's just the epidemiologic perspective. To answer Mr. Kant's second question, why the deaths? What we are seeing now is basically the reach of the virus getting into those vulnerable populations as community spread continues. The fact that anyone can be exposed by anyone else does put everyone at risk, and where vulnerable people are exposed, vulnerable people can have more serious illness and they have worse outcomes. So that is why we're seeing additional deaths at this point in time. We are again asking that people who know of their vulnerabilities, know that they do have pre-existing comorbid conditions, diabetes, hypertension, other chronic diseases, that you don't take any respiratory symptoms lightly, that you seek care early, and that you ensure that if your symptoms are worsening, that you seek emergency care via the emergency rooms, and you'll be shunted to the correct part of the health system. So we're not awaiting a test result, and we're not awaiting severe illness. Even moderate illness in persons with underlying conditions should prompt the active seeking of care. I hope that answers the question.
Thank you very much, Dr. Hines. And now to 98.1, we're ready for your questions.
And good morning to you, Ms. Alcantara, and to the panel, Stephen Cummings, 98.1 FM. I have two questions, one for Dr. Hines and the other for Minister Dayal. I begin with Dr. Hines. Dr. Hines, there is a lingering view that there might be some deleterious effects on general body health if there is an almost continuous breathing in of carbon dioxide and not enough oxygen intake with face coverings, which has now been legislated. What is the effect of this action, if any, on the body? In fact, we may be inhaling air, inhaling air or substances that are meant to be exhaled. So if you can respond to that from a technical, viewpoint. And Minister Dayal Singh, I'm always mindful of the country's COVID-19 caseload per million. There has been an exponential increase in the numbers in several of the categories. We are now at 2,254 positives with 35 deaths. In the first wave, we were at 8 for a while when we began giving our local caseload. Where are we now as of September 7th? Thank you.
So thank you. I will let Dr. Hines go first while I gather the information for you, Mr. Cummings.
Okay, thank you, Mr. Cummings, for your question. I'm happy that you've raised it because I'm hoping that today we can put that to rest. The wearing of a face covering, even if it does cover your nose and mouth, the face coverings that we are suggesting, be they cloth masks or surgical masks, are not designed in such a way that they prevent the entry of oxygen. Oxygen is a tiny molecule that can get into, through, and around the mask without any difficulty whatsoever. And they're also not designed in such a way that they trap carbon dioxide, which is another tiny molecule that gets out of the mask with equal ease. We have seen several videos by medical personnel who have demonstrated with objective measurement tools, both pulse oximeters and capnometers being the ones that measure carbon dioxide levels in the bloodstream, that these levels are not affected by the wearing of a mask even over protracted periods of time. Something that should be obvious because the medical professionals who are required to wear masks during the course of their daily activities do not suffer from hypoxia or hypercapnia, meaning increased carbon dioxide levels. So these would not be scientifically valid or sound reasons to be unwilling to wear a mask. Added to that, the legal requirements are for a face covering of a few different kinds. We would encourage persons to wear masks where possible, and those who for any reason absolutely cannot, another one of the face coverings prescribed in law can be utilized. But the objective of the mask is to prevent the expulsion of droplets and to prevent you from being a risk to other persons with whatever you do exhale. And for that reason, we're going to continue to advocate for and insist that the face coverings be worn as now prescribed in law.
Okay, so I will get back to Mr. Cummins's first question. No, coincidentally, Mr. Cummins, on Sunday morning, I called Dr. Hines to tell him I was working out some figures, but I did not trust my math. And could you work out the same figures without knowing what I got? And luckily, my math was correct, as validated by Dr. Hines. So I will give you those figures. So, on a global scale, the world is now experiencing 3,507.3 cases per million population. Trinidad and Tobago's caseload on that same parameter is 1,607 cases per million. In Trinidad and Tobago, we worked out these figures between Dr. Hines and myself. The positives, and that was really a good question to put things in perspective. The positive cases as a proportion of the total population of 1.3 million people, I think 1.399488, turns out to be 0.145% of the population. Correct, Dr. Hines?
Correct.
You and I got the same figure. So positives, let me repeat it. Positives as a proportion of the total population is 0.145%. The other statistic that we worked out is our case fatality rate. That is the number of deaths over the number of positives, 1.5, which is actually below, I believe, global levels, Dr. Hines?
At present,
yeah.
yes.
So we are below global levels with our case fatality rate. That is just a number. I will give you our positivity rate because we worked this out too. Our positivity rate, which is the percentage of total unique test positive, is 9.4. So those are 4 statistical measures that we are using in Trinidad. And the reason why we have to use these measures is because we said our strategic objective, which is still valid, is to turn this country back from community spread to cluster spread. And we are steadfast in achieving that, that strategic objective. And these are the measures that we would use. Caseload per million, Trinidad and Tobago, let me just repeat it, 1,607, as opposed to the global average of 3,507. So we are just about 50% of the global average. And the percentage of the positives as a proportion of total population, 0.145. Case fatality rate, 1.5. And positivity rate, 9.4. Thank you very, very much, Mr. Cummins, for raising that issue.
Thank you very much. And we go now to AZP News.
Hi, good morning. Priya Bihari, azpnews.com. Some time ago, Minister, I've been asking about if you all found out how case 139 had contracted the COVID-19. What I was getting at is that if analysis has been done in terms of the ministry to actually see when we actually started this second wave, if you know, so we wouldn't make that mistake again, or we put things in place to prevent such an occurrence of the community spread that is taking place now. That is my first question. And my second question to Dr. Hines, you said we shouldn't worry about the exact locations where there are COVID-19, but certainly there are certain areas where there is an intense concentration of COVID-19. There could be somebody who is on your street in self-isolation. Should these people then, and these areas where there's an intense number of COVID-19 cases, should they be more concerned than others? And if not, why not? Thank you.
Okay, thank you for your questions, Mr. Bihari. With regard to case 139, I do recall that this question has come up. The information provided by the individual in question did not lead to the identification of where they may or may not have been infected. When we do that case investigation, when we do that contact tracing, we do 2 things. We attempt to verify the persons with whom the confirmed case may have been in contact prior, no pun intended, to their exposure in order to see where they may have been exposed, where they may have gotten their illness. And we also see the persons with whom they were in contact subsequently to reduce the risk of spread throughout chains of transmission. As we said before, sometimes the individuals with whom we speak they don't know where they may have been infected. The information that they provide does not give us conclusive evidence. And in the case of 139, where we've completed that case investigation, there was nothing that specified pinpointed a source of infection for that individual. But we did count from case 139 go forward as the start of the local cases. So that has not been missed because we weren't sure where the person got the infection. We have pinpointed case 139 come forward as phase 2. That's where we start off phase 2 from, when we see the distinctions made in all of our diagrams, graphs, etc. So thank you for raising that and for allowing us to clarify. With regard to the areas where individuals may be self-isolating and the concern of their neighbors, I would again want to emphasize that everyone should exercise the exact same levels of concern and caution with their exposures, with their interactions. With anyone with whom you interact, you are expected to A, wear a face mask, B, maintain the physical distancing, and C, wherever it is necessary, also the hand hygiene and other hygiene practices to reduce the risk of sharing droplets via shared surfaces. That's not going to change whether your next door neighbor, 2 people down the road, or somebody around the corner has it. We're asking everyone to do the same. So that's the if not, why not, with regard to your second answer. Ms. Alcantara.
Thank you, Dr. Hines. And now, TTT.
Good morning, everyone. My question is for the Health Minister. So there are now legal repercussions as it relates to non or improper mask wearing. Are you aware of any employers handling COVID-19 reports improperly? That is, whether or not they treat with these reports carefully and ensure that other members of staff who might have come into contact with the positive person, whether or not they get isolated and subsequently tested. And should the health ministry become aware of such practices, what type of action can be taken against the employers who don't want to risk the downtime for their businesses? Thank you.
Thank you very much, Christelle. I think that question was asked in a slightly different way on Saturday. And I think the chief medical officer did indicate at that time, Candice, you could correct me if I'm wrong, there is no legal framework or requirement to hold employers accountable. What we are asking employers to do is do the simple temperature screening. Those machines now are so cheap, and that is a good screening mechanism to make sure that people with fevers don't come into your business place. The chief medical officer also advised businesses to set up pods of workers. Don't have all your workers commingling. So if you have a production line, you separate them both physically. Make sure one pod goes for lunch at a particular time so the pods of workers don't miss. That way you could mitigate risk. There's a lot of common sense things that employers can do to mitigate risk. But right now, there is no form, to the best of my knowledge, maybe Dr. Hines could assist me here. There's no formal reporting mechanism in law that I believe is there, and I think the chief medical officer did address that on Saturday. I don't know if Dr. Hines wants to clarify or add.
Okay, just to add, thank you, Minister, to the response. While there isn't a formal mechanism for seeking legal redress, there are, of course, mechanisms for seeking additional guidance from the public health personnel in how to handle an exposure situation within a workplace. This is activity that is ongoing. We have continually provided that sort of guidance to workplaces that have reached out either to the Epidemiology Division, to the Ministry of Health, to the county medical offices of health. And this guidance is really along the lines of how to expedite the contact tracing process, isolate the appropriate persons, and ensure that there is minimal disruption, although some disruption is inevitable. And on that point, I would really like to emphasize that keeping ill individuals in your workplace is going to result in greater disruption than having 1 or 2 ill persons out. The faster we can identify that someone is unwell and that they should not be at work, the faster we can reduce the risk of other workplace colleagues being exposed. So quickly removing and isolating one ill person is the best way to ensure that your productivity and your business continuity is maintained, as opposed to keeping ill persons within the workplace. So we do want to emphasize that and to ask people who do not feel well not to turn up for work in the first place.
Two other things, because Crystal really raised a very important issue. CMO did say on Saturday we do have the public health inspectors that could be relied upon, and especially large and medium-sized businesses do have OSH departments. So this is a time for corporate Trinidad and Tobago and the public sector to really empower your OSH departments to get involved with the Ministry of Health, because the Ministry of Health can't be everywhere at the same time. So we need to have this cooperation across sectors. Companies now empower your OSH departments to get on board with the guidelines. You have the Ministry of Health guidelines. You have online guidelines put out by CDC, by WHO, by all the big consultant firms, McKinsey. They're all basically standardized. So this is a time for corporate and the public sector to really empower your OSH departments.
Thank you very much. And now Express newspaper, we're ready for your questions.
Good morning, Kim Bojram from the Express.
Morning, Kim.
Good morning. To revisit issues that would have been ventilated, contact tracing at this stage, given our rates, is contact tracing still relevant at the rate that we may be doing it, which I can't put a figure to that rate? Does it make sense still to expend resources looking for dozens of people? And can those resources, are they convertible and can be used instead perhaps to keep checks on whether or not businesses are doing their protocol, or to make sure people are quarantining, just to get a sense of if contact tracing is still relevant at the rate that we might have come to understand it earlier on? Also, to revisit the businesses and the protocols, for instance, at the doors to prevent spread. The bigger businesses certainly have established certain things. For the small retailers, again, how do we keep check on them? And the temperature checkers that they are using, these little devices, may we ask, where do they come from? I mean, does the ministry keep a check on where the devices are coming from? A lot of people are using the same device. Sometimes you will see several people, customers, for instance, in a row showing the same temperature. Is there a standard that governs, the quality of these devices? And again, with the sanitizers, how do we make sure that the smaller retailers are not just spritzing people with watered down alcohol, for instance, to save money? These are micromanaging details, but can we get, how do we really manage some of these issues then? Thanks.
Okay, thank you for the question. With the first question, I think, is the real crux of the matter, and I'm happy that it was raised. Yes, contact tracing at this point in time is of very great relevance. This is the way in which we prevent rapid and uncontrolled spread from known positives. We do acknowledge that there will be people with mild illness that may not ever show up, and that we hope are taking the advice to self-isolate so that they do not create a web of contacts. But for the persons who have been identified and confirmed as COVID-19 positive cases, we make the extra effort to ensure that their webs of contacts do not all come down with illness, that the entire workplace does not go down because one person who was exposed remains in circulation, develops illness, and passes it on to additional individuals within the workplace. So contact tracing is of even more relevance now as we attempt to put the brakes on that community spread. That's one of our braking mechanisms. It's one of the ways of taking exposed and ill people out of circulation. To give you a good example, the situation that would have arisen with the police recruits in the police academy. 2 individuals initially tested positive. Those who were A, exposed, or B, symptomatic, were all taken out of that situation so that the remainder did not also become ill in sequence. So yes, contact tracing, very important. With regard to the handheld and other temperature scanners, while I cannot say for myself where they come from, they appear to be fairly standard. The temperature of an individual is only one of the layers of checking that we'd want to do. Having already asked ill people to remain at home, having already asked symptomatic people to do either one of two things, stay in your house or go to the health facility closest to you for health care. Other individuals who may have a temperature can be picked up in this way. I believe those instruments are fairly standardized. We can get additional detail on that. And the hand sanitizers, I'd like to remind the population that you do have access to your own hand sanitizers, so you can sanitize your own hands with your own sanitizer going into the places where hand sanitization may not be easily available, because we cannot micromanage every single individual business place and quality check the concentration of their hand sanitizer alcohol. Thank you for the question.
Thank you, Dr. Hines. And now questions from I-95.5, please.
Yes, good morning to everyone. Whitfield Turner from I-95.5. Just to piggyback on one of Kim's questions, Minister Diallo Singh, what would you say are the top 3 areas of the COVID fight that the system is under the greatest amount of strain, if you can pick the top 3? And my second question, there's an experiment that's now taking place overseas. I don't remember the exact country, but it's taking place where persons who have recovered from COVID-19 are now volunteering at hospitals that are treating COVID-19 patients, basically to try to buoy their spirits up to help them to fight the virus. How likely are we to see a similar undertaking like that here in Trinidad and Tobago?
Thank you, Whitfield, for your question. The main concern that I, as Minister of Health, have now is one that I raised in my very first press conference after being appointed Minister of Health for the second time, and I said it out loud and clear. The major concern, you asked for top 3, I will give you the top 10. Number 1 is protecting our healthcare workers from burnout. Number 2 is protecting the healthcare workers from burnout. Number 3, 4, 5, 6, 7, 8, 9, and 10 is protecting healthcare workers from burnout. That is the major concern facing us now. And we can do that if this new demographic, 25 to 49, would simply abide by the health regulations, stop having your underground parties. The police had to arrest persons in South Trinidad in a bar. Let me repeat, I have nothing against bars. I used to lime in bars. But in a pandemic, where you have a communicable disease, has been proven around the world. Social settings is what is driving this second wave. When we closed down nurseries and preschools in the very first lockdown in March, they have not yet opened. Because wherever you have congregation of people, whether it's in a nursery with children, a preschool with children, a place of worship, because we also shut down places of worship again, and bars. This is not an anti-bar issue. It's an anti-congregation issue. And we are still getting reports that people are congregating 25 to 49 years in settings where masks are not being worn, yes, where social distancing is not being practiced. You take the virus home because somebody asked, why are so many elderly people dying? And you infect the elderly. It's a chain reaction. So my top 10 concerns are preventing burnout of my healthcare workers, with whom I have the deepest respect and regard for, and I am just asking the public to respect them by not endangering their lives, their positions.
Thank you very much. And the second question on the experiment with recovered patients motivating those who are currently in hospital, Minister or Dr.
Yeah,
Hines?
I will deal with that because that's really a policy issue that the minister will have to make. It is something I don't make policy on the fly because a question is posed to me. There seems to have some logic to it, but I could also foresee the dangers because you are getting reports, although it's very small numbers, that people are being reinfected. I would not like the one to take the responsibility of putting a recovered COVID patient into a setting where they may have a chance of contracting the virus again. There is so much that we do not know about the virus. So it's a policy decision I would not make because a question is posed to me. I could see both sides of the story, but the pessimist in me and that part of me that acknowledges there is too much that we don't know, I will tread very lightly. I don't know if Dr. Hines has a different view or whatever. We can put him on the spot. You are free to disagree with me.
Minister, although I am free to disagree with you, I most heartily concur. At this point, where we do not know how long immunity lasts, where we are beginning to see reports of reinfection, this is not the time to experiment blindly. And we will look at the outcomes of said experiments in other countries, as well as the science behind the immunological response before making a decision along those lines. Candace?
Thank you very much. And now, Newsday, we will take your questions, please.
Yes, good morning to Ms. Alcantara and the panel. Julian News from Newsday. Two questions. The first, good morning, Minister. Two questions. First question to the Minister. We identified the 25 to 49 age group as pushing the spread of the virus. I'm wondering, do we have special targeted messaging for this group, or is it being developed? And my second question, I believe, would be to Dr. Hines. The persons we have quarantining at home with mild symptoms, just how has the compliance been for that group? Those are my two questions. Thank you.
So thank you, Julian. We are embarking and have embarked on a total revamp of our messaging for COVID-19. You would have seen some of that on the new TV ads, asking people to wear masks. You are seeing more and more of it in the newspapers, and you will be seeing more of it rolling out in the coming weeks and so on. But the message remains the same. Do the normal things, and we can have a good plan moving forward, taking us back from community spread to cluster spread, to directly target and reach that same demographic, Julian, that you spoke about. We are using the platforms that they use because we recognize they may not look at TV. We recognize they may not read newspapers. So we are on the platforms that they use, like Instagram and Twitter, to reach that exact demographic that you have spoken about. So thank you. It's good advice, and it's something that we will deepen in the coming days and weeks.
Thank you very much. And I think that's the only question from Newsday.
No, there's a question on compliance.
Okay,
yes.
Let's go.
And that, again, is an excellent question. The process for monitoring the individuals who are in home quarantine involves daily calls to verify whether symptoms have been developed. Home isolation, which is the process that applies to those individuals who are already ill, also involves daily calls to see whether symptoms have worsened. When we interact via the offices of the CMOH with the individuals in quarantine, we do also ask them and remind them to remain indoors, and we ask whether that has been done. Generally, the answer we get is that verbally there has been compliance. We have had one or two reports of breaches of quarantine where we had to engage the TTPS to assist in ensuring that people do not wander too far from home, but generally compliance has been reported to be good. Ms. Alcantara?
Thank you very much, Dr. Hines. And our last questions today, we go to TV6.
Hi, good morning. I have two questions. I'm building on the question about the home quarantine. Could we have more details about that? Specifically, have we been seeing cases of onward transmission among family members? Have persons been having to be readmitted in any significant numbers? And the second question, I know you said a short while ago that there's still a lot we do not know about the virus. And I recall some time back seeing an article on Forbes about the WHO saying they have emerging evidence that it could be airborne. Do we have like any latest information on this?
Yeah, so I'll take the second question first. Yes, there is emerging evidence that with aerosolization, the smaller particles, especially in an air-conditioned setting, can stay in the atmosphere a lot longer than we originally thought. So yes, and that's why we keep on saying there is so much to learn about this virus. But until we understand the virus, we must do the common sense public health measures, which we have been extolling the virtues of over the past months. Thank you very much.
And to tag on to the Minister's response, the aerosolization to which the Minister would refer would be in specific settings where specific activities happen to generate aerosols. It does not mean that that is the main mechanism by which transmission occurs, but just that it is an additional mechanism which should not be ignored or discounted. And as we have seen, the risk within situations where air is being recirculated is higher if you have an aerosol generating procedure inside of those sorts of settings. For that reason, hospitals have particular rooms where they do aerosol generating procedures. They generally would want to do those under negative pressure. That kind of activity helps to reduce the risk of this of transmission via those means. Added to that, the question that was asked about quarantine and onward transmission in homes, this is a good opportunity to re-emphasize that the home quarantine and home isolation guidelines do include behaviors and steps that people should be taking in their households to reduce the risk of transmitting to other persons. If you are ill, then you are asked, beyond remaining in your household, to actually remain in a given room, to use single-use items for eating and drinking, to clean down the shared surfaces that you may use in the bathroom. Those sort of things are the steps that we take to reduce the risk of onward transmission within the household. We have seen situations where entire households become ill. Yes, we have noted that, not just during this phase of home isolation, but also prior to that via the contact tracing activities that would have been done. We did find other people in the households being ill even when they weren't isolated and required to remain in the household. So yes, onward transmission in a household continues to be a risk. Now, those guidelines of which I spoke with regard to preventing transmission in the household, those are actually on the website, and this is the Ministry of Health website and the Ministry of Health social media pages. These are home guidelines for reducing risk. So we would encourage everyone to go take a look at those if we have not done so before. Ms. Alcantara?
Thank you very much, Dr. Hines. And we go to Ms. Sukhchand for just a final reminder about immunization.
Thank you, Candice. As parents and as adults, we know the importance of a car seat to protect your children. But did you know that one of the best ways to protect your children is to make sure they have all their vaccination? Immunization can save your child's life. Because of advances in medical sciences, your child can be protected against more diseases than ever. Some diseases that once injured or killed thousands of children have been eliminated completely, and others are close to extinction, primarily due to safe and effective vaccines. Polio is an example. Please take your children to the health center. Please ensure your children are vaccinated. And again, as I reiterate, contact your health facilities if you are unsure of what vaccines your child is supposed to get. Thank you, Candice.
Thank you, Ms. Sukhchand, and thank you, everyone. We have come to the end of today's media conference. We want to remind you, if you feel ill with any of the symptoms of COVID-19, please stay at home. Everyone be safe and wear your mask.
This is TTT. Live for local.
As the number of COVID-19 cases rises and children are at home because of the school closures, here are some things that you can do to continue to keep your children safe and protected. Tip number 1. If you have to leave home, ensure that your children are in the care of a responsible adult. Tip number 2. Listen to your child. If he or she indicates concerns, find out what the problem is, and if needs be, contact the relevant authorities. Tip number 3. Try to keep your children engaged and supervised at all times. Develop a routine that includes academics as well as games, and allow them to connect virtually with their friends. Finally, remind your children to continue to practice good hygiene habits and social distancing for the period that they are at home.
I solemnly pledge to dedicate my life to the service of my God and my country. I will honor my parents, my teachers, my leaders,
and my elders, and those in authority.
I will be clean and honest
in all my thoughts,
my words, and my deeds. I will strive in everything I do
to work together with my fellow men of every